Okay, it looks like we have most of our committee members, so I'm going to go ahead and get started. Good afternoon, everyone. Thank you all for joining us today for the Advisory Committee on Data Issues. Remember to raise your hand and turn on your microphone when you're ready to speak, and mute your microphone again when you have stopped speaking. As I mentioned, this meeting is already being recorded. The recording will be posted on the Advisory Committee's webpage shortly after the meeting. And for everyone's reference, today's agenda can be found under the first tab in the meeting materials. And I will go ahead and turn it over to our committee chair, Bianca Frogner.
Hi, thank you, Rochelle. Welcome, Advisory Committee members. It's now 3:37. I call the August 21st meeting of the Advisory Committee on Data Issues to order. I am Bianca Frogner, the Advisory Committee on Data Issues chair. So we have some informative discussion regarding the expansive subject of business oversight today in support of the Cost Board Policy Study Priorities. So let's go ahead and open to the agenda, tab 1. I'm going to provide an overview of the agenda. So, turning to that tab 1 of the meeting packet, we'll start with a brief overview of the agenda, introduce a new member of the committee, then proceed to roll call. Next, we will approve the meeting summary from our June 12th data issues meeting, which was not a joint meeting. It was just a data issues meeting. We will hear public comment concerning the materials covered in this meeting. Following that, we'll have Janine Smith from Health Management Associates, who will provide a quick recap of study related to business oversight by the board and committees to date, and we'll introduce a panel. Let's see, so Janine will introduce a panel providing perspective from each of their 4 state agencies regarding this topic, what data is available, and what would be useful to have. The meeting will conclude with a discussion on the subject as we consider what recommendations could be made to the board to fill some of the gaps in existing data in order to improve affordability. So now we'll go ahead and start by doing roll call. I will call members by first name in the order that they're listed on the agenda, which is in alphabetical order by last name. So first up, Krista.
Good afternoon, everybody. Krista Abels here.
Thank you. Good to see you. Megan. Megan? Oh, I see. Well, let's see. We have Mandy saying she's here but can't answer the roll call. So we'll come to that. Amanda? Not hearing Amanda. How about Jonathan?
Yeah, good afternoon, everybody. Jonathan is here.
Thank you, Jonathan. Bruce. Is there Bruce on the line? No, not hearing that. Anything? How about Jason? No? Okay. How about David D? If staff can also let me know if anyone shows up here that I might be missing. How about Chandra?
I'm here.
Great. Thank you, Chandra. How about Leah? I think I see you.
Hello, I'm here.
Great. Thank you. Li Chu?
Yeah, I'm here. Li Chao is here.
Li Chao. Sorry. Yes, thank you. David M.
David M. is here.
Thank you. Anna?
Hi, everyone. I'm here.
Thank you. How about Hunter? Hunter? Not seeing Hunter. How about Mark?
Here.
Thank you, Mark. Russ?
I'm here.
Great. Thank you, Russ. And then Mandy, who said that she's here but can't answer the roll call. So anyone that I missed? I know there was also, let's see, Julie, who said that she wasn't able to make it today. Anyone that I missed? Okay, not hearing anything. Let's go ahead and move forward. Thank you to everyone for being here today. Let's go ahead and open to tab 2, meeting summaries. And let's go ahead and approve the meeting summary now. As a note, the recording of the last meeting is posted on the webpage for reference. We will use the consensus process for a vote on the approval of the meeting summary from June 12th, the last time this committee met in a non-joint session. So first, is there any discussion of the meeting summary? Any proposed changes that people want to discuss? Feel free to unmute yourself or raise your hand. Not seeing any comments on the prior meeting summary. So let's go ahead to see if we have a motion to approve the minutes from anyone from the committee.
Bianca, it's Russ. I'll make a motion to approve the minutes as written.
Thank you, Russ. Is there a second?
I'll second it.
Thank you, Krista. Thanks for a second. All in favor, say aye.
Aye. Aye.
Okay, great. Any opposed? Okay, sounds like motion approved. I'll pass it back to Rochelle for the next section.
Thank you, Bianca. We did not receive written public comment prior to the meeting, so I would like to welcome any public comments at this time. If you would like to provide public comment now, please raise your hand using your Zoom controls. When you're called upon, you will be invited to join the meeting as a panelist. To enable speaking, please join the meeting as a panelist and unmute yourself. Please state your name and affiliation, if any, before speaking. And please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide public comments in writing via email at any time. And please remember that this is the time for public comments. The remainder of the meeting is designated for advisory committee members for questions and discussion. So I'll now open the floor to public comments. I am not seeing any hands raised, but I will just give it a minute to see if there is anybody that would like to have a public comment. Okay, I will go ahead and turn it back to you, Bianca, and close public comments. It doesn't look like there are anybody in the audience that has their hand raised.
Okay, thank you, Rochelle. I appreciate that. So let's go ahead and open up tab 4. And here I'll give a very brief overview, review of topics that were discussed at the July 30th cost board meeting. So just one second here. So on July 30th, we had a cost board meeting where we had a facility fees panel, and then the members of the board had a discussion about it. The discussion and presentations were both from a national perspective as well as a provider perspective. And then there was a discussion about potential policy recommendations around facility fees. Also, what took place at the cost board meeting was a new committee member nomination from the nominating committee. From the stakeholders group, a nomination was for Michelle Ritala. I apologize if I'm saying her name wrong. And from data issues, David DiGiuseppe. So I will go ahead and trying to navigate a couple of screens here. So I'm going to turn it over to Janine Smith of Health Management Associates, who will lead us in a discussion of the current landscape of business oversight in the state of Washington and potential policy options which could increase transparency. This presentation can be found on tab 4 of your packets. So welcome back, Liz. I'll turn it over to you.
Thanks, Bianca. I just want to give a real brief overview of where the business oversight work has gone. So I can get us over to our excellent panel, which will have more detailed discussions. So just a refresher, the board had policy options they considered at their retreat back in February. And there was a lot of interest around mergers, acquisitions, private equity, and ownership closures. And they simplified the concept into business oversight. So that's where the term came from. And they'll be addressing and looking at the others on this list, but we're going to focus today discussions related to the business oversight. Next slide. And during our board meeting in May, we took a view of looking across the states nationally to see what kind of authority existed. And you may have seen some of the materials from that meeting. And that's where they referred further work to this Data Issues Committee for further study to help them make some recommendations about what kind of data collection is missing and what might be useful for greater business oversight. This table shows you where there is authority and it highlights some of the areas of Washington state versus some of the other states. Next slide. And then you all at your June meeting, we talked about the data issues in terms of when is the data collected, who's collecting it, and what's captured, what's not. And today's panel is going to talk a little further because we have representatives from some of these areas to get a kind of a deeper dive into what would be useful versus what is already collected and how it can maybe be more efficiently assessed. Next slide. So with that, if we have, I think all of our presenters are on, but today's panel will start off with Jane Beyer from the Office of the Insurance Commissioner, where she is the Senior Health Policy Advisor, and she is also a cost board member. And then following that will be the Office of Financial Management, Mandy Starer, who is also a Data Issues Committee member, but where she works over there at the Senior Forecast and Research Manager. And that will be followed by Travis Kennedy, who is an Assistant Attorney General in the Antitrust Division of the Attorney General's Office. And then Ian Doyle from the Department of Revenue, who's a tax policy specialist with legislation and policy, will wrap up our panel. So with that, is Jane, are you ready to go? We'll get your slides up.
Hey, so good afternoon, everybody. I'm going to talk today a bit about some of the findings that we have in a healthcare affordability report, and kudos to the folks at HMA who were our contractors on this and did the vast majority of the heavy lifting, specifically Gary Cohn leading that team, and talk to you about sort of what we found in that report, and then sort of segue into the discussion about where there was some information that were sort of identified as gaps. So next slide, please. For those of you who aren't familiar with it, the legislature directed the OIC in 2023 to do a 2-phase affordability report, and they also directed the Attorney General to participate in that work. So in December of last year, OIC and the AG's office each released preliminary reports, and then OIC's final report was released on August 1. Next slide, please. And here we went through in the preliminary reports, what we really wanted to focus on more than anything else was, if we're going to be helping to inform the legislature's considerations of affordability options in Washington state, what information do they need to know sort of as baseline? And really that was about what's the structure of our current healthcare system. including information about vertical and horizontal consolidation among insurers, hospitals, and providers. Also trying to better understand the role of private equity investment in Washington. And then we listed out a long list of potential policy options related to affordability. The AG focused in their report on really just what's the antitrust legal environment that healthcare is operating in, and then really focusing in on oversight of merger and acquisition, which you'll hear me refer to as M&A activity, and also looking at provisions in the healthcare industry that are non-competitive, such as non-compete agreements and anti-competitive provisions that we see sometimes in contracts between insurance companies and providers. Next slide. And next slide. So what did we find when we looked at the healthcare system? Well, we found that there is vertical integration and horizontal consolidation definitely in Washington State. As you can see here, 40 of about 100 hospitals in the state are part of the 5 largest hospital systems. 15 are part of smaller multi-hospital systems. About 80% of all licensed beds are part of multi-hospital systems. And we can definitely see vertical integration among hospital systems or within hospital systems, ownership of skilled nursing facilities, hospital-affiliated clinics, freestanding clinics, and home health agencies. And we found that about 50% of physicians are employed by hospitals, and of those, about 2/3 are employed by the multi-hospital systems. We also found and know that there is a significant amount of physician employment outside of hospital systems, probably one of the most notable examples being the Everett Clinic and the Polyclinic that are both owned by Optum. Next slide, please. And we wanted to make sure that we weren't just looking at what was happening on the provider side. We wanted to see what was happening on the insurer side. And what we see is that insurers or their holding companies, a number of the licensed insurers in Washington State are actually part of a broader holding company. So, for example, Premera is the holding company. Premera Blue Cross and LifeWise are licensed health carriers that are underneath that holding company umbrella. And when we looked at it, we found that insurers or their holding companies have definitely integrated with other sectors, including PBMs, the actual delivery of pharmacy services, i.e. mail order pharmacies, acting as healthcare benefit managers, either for the holding company or also for other insurers. These entities often act as third-party administrators for self-funded group health plans, and then also data and analytics. For example, United Health Group owns Change Healthcare, and Change Healthcare owns Interqual, which are clinical guidelines that are used by a lot of health plans. And so beyond acting as health insurers, we know that these entities are involved in numerous aspects of the care that Washingtonians receive. Next slide, please. And these next 2 slides, I'm not going to go over in detail, but these are among some of the biggest holding companies that operate in the state. These are just details around what entities they have vertically integrated with. Next slide, please. And next slide. And so we also wanted to take a look, as I mentioned earlier, at what's happening with private equity investment in Washington State. Clearly, it's a growing national trend. There's not very much public information available, and there is clearly some controversy about the impact on cost and quality of care. A recent review of 55 studies found that private equity ownership was most consistently associated with increased cost to patients and payers and had mixed to harmful effects on quality of care. We see private equity Originally, it started out, I think, looking at nursing homes, and now has really started to get more into specialty physician care and services like dermatology and ophthalmology, where there tends to be sort of elective procedures that may or may not be covered by health insurance seemed to be of significant interest. But we also see private equity investment in gastroenterology, primary care, and you can see all of the specialties. And then also other healthcare facilities and services. We're also seeing private equity come into purchase of behavioral health hospitals, so psychiatric hospitals. And we asked HMA to try to get a sense of the number of healthcare acquisitions that they had seen in Washington State over the last 10 years. So they identified 97, which was using the source PitchBook, which is a source that a lot of researchers use who are trying to assess what's happening with private equity acquisitions. And just a couple of examples in Washington State. Team Health does a lot of emergency medicine staffing at hospitals, including hospitals in Washington State. They're one of the 6 largest emergency medicine staffing companies. And then U.S. Anesthesia Partners operates in 8 states, and they are the largest majority physician-owned and led anesthesia group in the Pacific Northwest. The FTC recently filed a lawsuit against USAP for their activities in Texas. So that litigation is ongoing. Next slide. Okay, so in the final affordability report, we chose 5 healthcare affordability options to do a deep dive actuarial and economic analysis of. They include creating a reinsurance program, increasing the minimum medical loss ratio requirements that health insurers have to meet, using reference-based pricing for healthcare facility and provider payments, using hospital global budgeting, and then looking at what would happen if healthcare cost expenditure trends met the board's cost growth benchmarks. And we have links to the affordability report. And next slide. And so when we look ahead and we look at what the board has asked you to look into, there really were 2 issues that popped up when we were doing this work. First, we used the all payer claims database as our claims base or claims source for the reference-based pricing analysis. And what we found is that the APCD does not include non-claims payments. And you'll see there's a pretty extensive discussion in the report around the reference-based pricing analysis that indicates that we think the numbers that were generated by the APCD analysis likely understated the level of payment that was being made to providers and facilities in Washington State. And there's actually a lot of work going on across the states and with the National Association of Health Data Organizations to try to figure out how to integrate non-claims payment data into the all-payer claims database. It's also difficult to tease out facility fees from the all-payer claims database, which we know that the board has been having significant discussion about. And finally, we did find some real challenges in trying to understand all of the different ownership and affiliation relationships across and within not only the hospital systems, but also in and among the holding companies and the insurers. The information that was in the preliminary report was all based upon web searches and other public data. So we really do not have a complete picture of who owns what or who is affiliated with whom. Massachusetts has an ownership reporting program that they are actually working on updating now. Some of you may have heard about the Steward Health System in Massachusetts and several other states. That was a private equity owned system that filed for bankruptcy. And Massachusetts realized that their ownership reporting program does not currently require reporting related to private equity investment. And I also gave you a link to a recent blog post from the Center for Health Insurance Reform. And I must note that we will have a new insurance commissioner in January of 2025 who will decide what positions, if any, he or she wants to take on a variety of issues like those that are illustrated on this slide. But that at this point, the OIC is not currently taking a position with respect to whether the state should explicitly pursue these policies. So that's it for me.
Oops, sorry, I was muted. Next is Mandy. Are you, can you talk now? Well, she was on. We have her.
Know where she might be. I'm not seeing her in here.
She was on earlier when you did roll call.
Oh, that was a different Mandy. That was Mandy Weeks Green.
Can you hear me now?
There she
There we
is.
go.
Yeah.
Yes.
Sorry about that. I had headphones in and pressed the button and it hung up on me. So
Oh no. Glad to have you.
Oh. Fun stuff. Yeah, so I'm ready. I guess I should introduce myself. So my name is Mandy Starr. I'm the director of the Healthcare Research Center in the Forecasting and Research Division over at OFM. And so I'm going to give kind of a brief overview of some of what OFM uses with data sources and then some of the data issues that we have. So can I go to the next slide? So this is just a sample of some of the current data sources we use and some of them that we do get cost information from. Jane has talked a little bit about the APCD. That's one that we use quite extensively at OFM. It's, got healthcare claims data. It's got pharmacy and dental claims as well as eligibility files. So it's one of our most comprehensive data set that we have that has cost information in it. We also use hospital discharge data, which is called CHARS. That's from DOH and WISHA are the two that collect and administer that data set. That includes all the inpatient hospitalization data for Washington State, as well as observation and revisit data too. We also look at the hospital financial reports. So these are the ones that are posted on the Department of Health's websites. So we've had some of our staff have looked at mergers and acquisitions. We've also looked at things like nonprofit status and we've tried to look at some hospital ownership. We've looked at bed counts over time and some of the FTE counts from those reports. We also do a lot of forecasting data using Provider One data, specifically the eligibility files. And then survey data, which you might not think has information regarding the hospital financial pieces, but from survey data, we can get information about some of the impacts. So access to care, utilization of care, insurance coverage. So what type of insurance people have and whether or not they've had problems getting insurance coverage. And then we can also look at people's health status too and how access and utilization of healthcare services have changed over time. Can I see the next slide? So some of the current data issues that at least we've experienced when we've tried to dive a little bit deeper into data. Big one is about nurses. And so with the claims data, nurses tend to be included in the facility fees. And so we can't tell nursing FTE changes over time. And, Jane had mentioned some about recent private equity reports, and I've heard from some reports too. I was at a recent Academy Health conference. Private equity was a huge topic at that conference. One of the things that was brought up is that when private equity enters the scene, you tend to see a decrease in part-time FTEs, and part-time FTEs. A lot of that was affected was nurses. So we can't really see nurses because they don't submit separate claims to the APCD. So their time and effort is included in that facility fee. And so this is a limitation that we have with our current data. EHR data, we don't have access to that. And if we could link both EHR and claims data together, I think this would give us a bigger picture of changes that happen within the healthcare system when you see mergers and acquisitions or private equity enter the scene. Right now, we don't have access to electronic health record data. We are in the middle of trying to get some use cases built so that we can get access to EHR data. The other thing to remember is that both claims data and electronic health record data, these data exist for business reasons. So they're not necessarily constructed in a way for analytical data analysis. And so there is like a data cleaning, I guess is the best way to describe it. So when you have these large databases, you do need to manipulate and change the data and get it into a form that people can use then to run data analysis with. And all that takes a big time and investment to the APCD data vendor OnPoint. They take in all the claims from the insurance carriers and the different payers, and then they create the database and the data sets for all of us to be able to actually run data analysis with. There's also an issue that we run into a lot having to do with linkage. So trying to link these different data sources together and trying to look at patients over time or patients across facilities. This is an issue. I know it's not something that's unique to us, but whenever you're trying to look at patients in different types of data sets, member IDs are never the same. The way claims or the way observations per person may be linked to a person, the methodology may differ between groups. So data linkage just in general is a consistent problem that we've had, and that I think the state has had some efforts around creating sort of like a master patient ID, but I'm not entirely sure where we are with that. COVID kind of threw a lot of these efforts, threw a wrench in a lot of those plans. So another issue we run into is kind of the validation of current data sources, especially related to some of the financial information. So we can take the hospital financial reports, but validating it with another data source can sometimes be problematic. We can take the IRS Form 990s and pull some of that information out, but trying to have additional data sources that have facility, provider, hospital financial information in there, just to understand what we're looking at and to make sure we're measuring what we think we're measuring. This is a limitation to a lot of the data sources that we have access to. The other thing that we have is some of the timing of these corporate or business decisions. They may not be related to direct patient services, or we may not actually know when some of these decisions happen. So you may have, an announcement of a merger or an acquisition between two different healthcare systems, but what does that actually mean? What does the timing of that look like? And when do we actually start seeing changes? Those sort of dates of decisions, I don't believe we even have a source to really understand like when those happen. So understanding timing of those types of decisions and then being able to match it to changes that we see in patient care, it's a struggle that we'll have. And then cost and length of time to access data. I think I've kind of brought up some of this before, that it takes time to take the data that we do get to translate into data sets that we can use for analytical purposes. There's also skill set to look at healthcare data and to look at healthcare cost data too. So there's a lot of resources and investment that needs to be done on the researcher side with these types of data. I think that's all I have. Yep.
Okay, great. With that, we'll shift over to Travis, our representative from the Attorney General Office.
Thank you. Can you hear me okay?
Yes.
Great. Thank you. My name is Travis Kennedy. I'm a managing assistant attorney general in the antitrust division, and I manage the division's healthcare notification program. Let's go to the next slide. So the healthcare notice program is intended to protect healthcare competition in Washington. I think it's important to note that one of the goals is to deter anti-competitive transactions from happening in the first place. And so that's a little bit hard for us to measure, right? Because you don't really know what that didn't happen. But the idea is that there's some transactions that were not good that are being deterred because parties know they'll have to go through an antitrust review process, transactions that may have slid under the radar. So that's part of it. And then I guess the other part of it is obviously to give the office enough time, or give the office the ability to review transactions under the statute and determine whether the Washington Consumer Protection Act has been violated by a proposed transaction. And we look at a number of different portions of the Consumer Protection Act, including whether a transaction is an unlawful restraint of trade or whether or not it's a merger acquisition, which may substantially lessen competition. And we can also, in addition to state law, we can also enforce federal law under the Clayton Act. Right, and just a little bit about our division is we have 15 attorneys, and between attorneys and staff, we have 25 attorneys and staff combined, and we are a self-funded group. We basically are funded through the recoveries we are able to obtain within the antitrust cases and settlements we're able to obtain. Sorry, next slide. So the healthcare notification statute was enacted in 2019 and took effect in 2020. This is the statute that governs which types of transactions have to undergo review within Washington. And it also, it mandates what kind of information needs to be provided to the office and the penalties for failing to comply with it. On average, we do receive 2 to 3 notices per month, but it really depends on how busy the market is in terms of the amount of notices we received. So what the statutory text actually requires is that at least 60 days prior to a material change transaction occurring, the parties have to provide notice to the Attorney General of the material change. And a material change includes a merger, acquisition, or contracting affiliation between a hospital, hospital systems, or provider organizations. So on this issue here, just one thing to note is that it is not required for example, insurance carriers to necessarily report unless they have an affiliate that's involved in the transaction that kind of fits within that framework, or a private equity group. So this does not cover all transactions within the healthcare space, to be sure. The other thing I'd note is the amount of information that needs to be provided to the Attorney General's office is very, very limited. There is no requirement they provide any data to us. They provide who are the parties to the transaction, a brief description of the transaction, and where those parties operate within Washington. So no data requirement here, just when you file the notice. You can go to the next slide. Just really quick, it does apply to out-of-state entities in certain instances, and that basically the out-of-state entity, if it's involved in a transaction, needs to already have $10 million in revenue from Washington. So a wholly out-of-state company that doesn't do any business in Washington that acquires a company in Washington would not necessarily be subject to the statute. They have to have some presence here already. We'll go to the next slide. So in terms of data and when the Attorney General's office might receive documents or data, it basically comes through the request process of the Attorney General's office. We review every notice that comes in to our office, and we determine whether, based on that review, there might be a competitive concern under the antitrust laws. And if we believe there is a concern, we can request information directly from the parties. This could be informally and could include things like data requests. We may also, to the extent it's a more fulsome request, we might do a formal civil investigative demand, which is sort of like a subpoena in an investigation to the parties to produce additional documents or data. We may also, and often do, request documents and data from third parties through civil investigative demands, and this may include like claims data from payers, trying to understand each market participant's role within a geographic market, and looking at different the geography in terms of the overlap between the parties, and the looking at also the different services they provide. I would note here that this can often be a pretty time-consuming process because, as you can imagine, the payers receive a lot of different requests for information around the country, and so it's often not a quick process to get the kind of claims data we might like from the third parties. You can go on to the next slide. Thanks. It is also important to note that the statute has a very strong confidentiality section, which notes that information that is submitted to the Attorney General's office through the healthcare notice program is and should be treated as this in the same way that the Attorney General's office treats materials that we receive pursuant to a civil investigative demand. So what that means is that when they provide us information and we make additional requests, we have to protect that information, and we cannot generally disclose it outside of our office. But I'll have a little bit more on that in the next slide. So because the healthcare notice statute says we have to treat the documents and data the same way we would treat materials produced to a CID, I think it's important then you have to go to the Washington Consumer Protection Act, and it has very strong protections about that material cannot be disclosed outside of our office. And so, what that means is the materials are not subject to a Public Records Act. The materials cannot just be provided to any requester. It is a very limited use universe in terms of the documents and data provided. There's a limited exception in the Consumer Protection Act for very limited reasons. Certainly if the Attorney General's office files an enforcement action, we can use materials in that enforcement action. But even then, we're not allowed to disclose trade secrets publicly. We often, if it goes to litigation, we'll have like a protective order that would limit the disclosure of the data or documents outside of the litigation, outside of the parties. So, yep. Anyway, that was everything I had in terms of the data that we have at the Attorney General's office through our healthcare review program. Thank you.
Thanks, Travis. And now we'll move on to our last presenter, and then we'll get some discussion going about this and questions for the panel. Ian?
Yeah, my name is Ian Doyle. I'm a tax policy specialist with the Department of Revenue. I'm going to start off by saying that we don't have a ton of data in general on private equity ownership, but hopefully I can give you an idea of what kind of data we do have. Next slide. So taxes in general in Washington, they're reported in very broad categories. Lots of times we get questions about how much of this service is done or that service, especially in nonprofit and for-profit hospitals. It's filed in their taxes in a way that we are not able to break it down into individual services. It's a very broad categories that we receive this. And if a hospital were to have some private equity ownership change, most likely we're going to see some wholesale tax activity, some retail sales activity for the consumables that they'd be taking on. In general, they're going to be filing under public or nonprofit hospital business and occupations tax. It's a very broad category, as you'd guess. It encompasses almost everything that they do. Next slide. One of the areas where we're kind of blind is exemptions. So there are a lot of different types of tax preferences, such as credits, deductions, lower rates. Exemptions have been something that, depending on how they're written, we may receive no information from a business. It would not be included in a sales price, or it would not be taxable at all. And where a deduction, you're going to back out the amount of the sale. We would see that on a tax return, a deduction, but an exemption, you are free to just fully leave that off of your tax return. We do have a tax exemption study where we have different reporting obligations for different types of exemptions, and that gives us a good idea to make an estimate on how much exemption is worth for the state of Washington for the taxpayers' benefit and the citizens' cost. You can go to the next slide, please. Tax information is very safely guarded by the Department of Revenue. If there's a data request where you want to pinpoint a certain industry, we need to make sure that there's enough competitive taxpayers within that to provide the data. Lots of times that's at least 10 taxpayers, and no taxpayer can be the majority. So you can't have one business out of the 10 being 70% of the data that we're sharing.
John? We need to.
Looks like we might need to mute Liz there.
You gotta be ready in 40 minutes,
Does
okay?
someone help? Maybe. Thank you.
No worries. Again, confidential taxpayer information we cannot share without a business being willing to sign over. If you're looking for data on that particular business, there are very few exceptions for that, and that normally comes with a secrecy clause. The governor's office, certain members of the Senate and the House are able to receive this type of data, but they cannot share it. And if they do disclose taxpayer information, it's loss of office, multiple years possible in prison, and up to a $5,000 fine. So while we can share the data on a very limited basis, it's not very helpful for those in research settings such as this. And that's really all the department has in terms of hospitals and private equity ownership.
Okay, well, thanks to you all. I would open it up to the committee to see if there are any specific questions or clarifications people might want to ask any of the presenters at this point before we kind of get into our discussion questions. Any clarifications? Okay.
Maybe I have one question for Ian. This is Bianca. Just as you were kind of talking about those broad categories in this Department of Revenue, where does NAICS code fit in, the North American Industry Classification System?
Yeah, so those are business identifiers that really help the department. We're able to use them for things like fiscal notes and for data pulls in general. They are self-identifying though. If the department notices that most likely they're not in the correct NAICS code that they identified, we will try to make sure that they're in the correct NAICS code. But that's kind of the imperfections with the NAICS, is sometimes you're pulling in businesses and industries that aren't necessarily accurately reporting their NAICS code, at least for their Washington tax basis. So they are helpful in terms of data pulls, and it really allows us to grab more businesses usually than like a very specified requests on data. When we're able to take something like hospitals in general, we can provide data much easier.
Mm-hmm. Okay, thank you.
Yeah.
Okay, other questions or clarifications of Ian, Jane, Travis, Andy? Okay, I think we can move on to the next slide, just as we were trying to, next one. Sort of think through sort of the through lines of what all these different discussions have been, both at the last meeting and this one, is that there is some variable ownership and affiliation data that has, as Jane was saying, has made it very difficult to try to determine, who owns whom and who's vertically integrating and, having to go out to websites, etc. And often it's a retrospective database, looking backwards without, with some minimal reporting mechanisms noted, as Travis said, there was only a small amount of information that's sent in just for what they are collecting. And not always is it those that are connected with private equity. There, is some trying to get a better feel for mergers and acquisitions with a focus on the consumer impact is limited by the data. Again, the Attorney General is looking at it from does it lessen competition? But from the cost board perspective of trying to think about it from an affordability and impact on the consumer, it goes beyond just whether it's a change in competition, and then the data that is connected to any sort of mergers acquisitions that the Attorney General is looking at is very limited, and so you can't really get extensive documentation of this currently in Washington. The all-payer database, as identified earlier, does not have non-claims data in it, and that, as Mandy identified, that has been a challenge and is a challenge in many states, similar of trying to get that additional information. And it makes it difficult to assess facility fees, et cetera, and some of the lack of data. And then just trying to get some entities are exempted from reporting or not involved. A company could come in from out of state that doesn't have $10 million investment already going on in the state and do something and not necessarily have to report. So I think there is a lot of areas of adequate data collection to really get a full feel of how best to provide oversight to the healthcare system to work on affordability issues. Other thoughts? I don't know if Bianca and others that you sort of heard in the various presentations today. So again, the board is sort of wanting to think about what kind of recommendations you might want to make to them about what changes, if any, you would suggest. I think we could go on to our discussion questions and see what the members of the committee think. One question is, how could we use the data that's already being collected to better understand the impact on consumers and purchasers of consolidation and private equity? Anyone has some considerations or thoughts about this? Hunter?
Yeah, well, I'll more stick to the consolidation piece. And so I think, one of the core measures that, is used often for consolidation is the HHI score. And so I don't know how familiar the group is on that, but, it's a measure, approximately, 0 to 10,000. DOJ, FTC has different kind of guidelines on what they consider as a concentrated market based off that. And I think, for example, I analyzed the CHARS data set a lot, so inpatient utilization. But I can really only measure things based off, hospitalization counts, patient days, and, I can construct relative like HHI score there, but I don't have access to the payment data. And I think with that, with the APCD, understanding all of its limitations, it doesn't have, fully the whole population or the non-claims payments. It still would help us kind of avoid boiling the ocean, because we could still calculate, some form of HHI, stratified across different care settings, disease states, et cetera. So, and then we could measure with the payment, then with the HHI, what's the relationship between those, and see which particular areas we ought to, most kind of vet and emphasize our analysis on. There's still a lot of, key decision making that the analysts will have to do, like how do you define the service area, that you want to measure, but at least that is one way for us to get started, really more from a data perspective.
So trying to use the data across, so everyone is using the data maximally and more efficiently. Gary, did you want to add in some thoughts?
Thanks, Janine. Yeah, I just wanted to highlight and add a little bit of color to one of the comments that Jane made with regard to the preliminary report that HMA worked on and that was published last December. Part of that report was the goal was to describe the current healthcare system in Washington, particularly with respect to the degree of horizontal consolidation and vertical integration that already exists in the system. And we found that it was extremely difficult to get complete and accurate data on who owns what and who they are owned by. And in some, with respect to some areas, private equity being the extreme example, but even others, we were limited to, basically websites, looking on websites to see news stories or announcements or, other information that we could gather on ownership of healthcare facilities, plus a private subscription service called PitchBook, which is well regarded and well relied upon for this kind of data, but there are limitations to the use of the information from that source. As it happened, HMA had a subscription to PitchBook, so we were able to get some data from there. But and to contrast the information that's available with respect to some parts of the healthcare system with the data that's provided by insurers, for example. Insurers report annually extremely detailed information about their holding company structure, and what they own and how that ownership structure kind of works its way up. So I think it's worth considering whether additional data should be gathered by the state so that it can simply understand what the ownership relationships are and have an accurate picture of who owns what parts of the system. And I think that the board would be really interested in your thoughts on how best to do that. What would be the most efficient way to do that, the least burdensome way to do that? And in particular, I think it's important to also recognize that different aspects of this type of data are collected by different agencies in the state. And so there is at least a risk that the data is not well understood or centralized in any one place, that policymakers might look to be able to understand all of this. And so that raises the question of whether it would make more sense to have data reported into one place and then disseminated out, kind of similar to what Massachusetts has done. They've established a separate agency that is responsible for collecting a lot of the data regarding the healthcare system. So that's a question that I would pose to the group in terms of what are the gaps you think are important to fill, if any, and then secondly, is if there are, what's the best way to do that to make sure that it's done efficiently in the least burdensome way possible and in the way that would be most useful to the public and to policymakers.
Bianca, do you want to respond to that, or I know you
Yeah, I'm curious, maybe even a couple follow-ups to Gary and Hunter, both of who point out some interesting and important kind of concepts around this discussion. What is for Hunter, maybe just in terms of how, since you mentioned CHARS, and certainly I'm a little familiar with the data that's there, providing some data on hospital discharges and whatnot, how much that data can be integrated with like information that Jane presented on how there's some major health systems. There's only a few major health system players, and has that kind of connection been made between maybe what's happening in the data that's collected out of DOH versus what's collected out of OIC to kind of bring those two pieces together? And then the other part, I think, Gary, I mean, you're right. This is exactly the example of data doesn't sit all in one place. Data sit in many places. As you mentioned, PitchBook is certainly one of those data sources that can tell us a little bit about some of the mergers and acquisition areas. And I was wondering if you also had any experience with like CompuStat, or I think Thomson Global Mergers is another database that exists out there. But I think these can help us maybe use some other data sources I know researchers in the business community do use to identify where private equity acquisitions happen. And I think maybe going to Hunter's point of trying to identify like how does that relate to changes in market concentration of hospitals could be a useful step. So just some thoughts and reactions to those comments.
Yeah, with respect to CHARS, I mean, they do, release their different kind of data dictionary, hospital directory that then, allows someone to be able to look at kind of the parent, kind of affiliate, different lists. But I think it's largely what's already been kind of gathered, and because it's a little bit easier at a hospital level to be able to, differentiate between the different systems. It gets a lot harder when we're looking at more on an outpatient basis. So, CHARS relatively easy, but then when I think of transitioning to like the APCD, that's going to be a lot more difficult to make the similar kind of organizational kind of tie-ins and relationships.
Yeah, and we relied on PitchBook. We didn't look at other sources. I think that was more a function of the time and resources that we had available to us to do this report. So I'm sure there may be other sources that could be used to get a more complete picture.
Appreciate that.
Jonathan, I think, has his hand up.
Yeah, hey, thank you. So I think it would be helpful. I mean, we talked a little bit today from different perspectives about the information that's out there and how they've used it. Have we compiled a list or a library of these various data sources, the strengths, the limitations? I think that would be extremely helpful. I think today's presentation was helpful in the sense that it was at a very high level. I think the expertise of this group is that we are often using this same data sources, and so we have a lot of input and feedback that we could provide. I think another big piece that I was thinking about is there's a ton of information both from the state and the federal standpoint, and digging into that, I think collectively could help shape kind of future conversations around this. But as far as some of the consolidation pieces, I'd also want to make sure that we're not just focusing on the merger aspect of it, but we're hearing a lot from our members around consolidations. It is happening at the provider level. It is happening with hospitals and hospital systems. But have we looked at those communities to see if they're better off or they're worse for those mergers? So there's that aspect of it as far as access and care. And I think that's a piece that often gets neglected. So we'd love to have that, make sure that that's incorporated into the conversation moving forward, because it's an important aspect of it. If you look at Washington State, our beds per census is the lowest across the country. We're already limited as far as access goes. So we also want to look at kind of the unintended aspects of these mergers and ultimately what they're doing, because oftentimes these mergers are happening because financial distress. I mean, if you're looking at some of these communities where we're seeing some of these mergers, they have a higher proportion of Medicaid and Medicare patients. In order to continue to be viable, there has to be changes there. So I think looking at it through that lens is also going to be very important.
So it does seem though that if you don't have accurate information, it's really hard to then go on and study the actual impact on access. I think as Hunter raised, if we had access to a little more data, more expansive data, then you could actually maybe do that.
Well, I think that's where the expertise of this group, right? Like, I don't necessarily agree with all the points that were shared together. That's why I think some dialogue would be helpful as far as maybe some of the strengths and limitations of the current data sources. I think the answer that we always fall sometimes often too quick to is we just need to collect more and more, where we're already collecting a ton of information at the state as well as the federal level, both from a finance perspective, utilization perspective. There's a ton of information out there, and I think there needs to be dialogue around that before we go quickly asking for more. I'm not saying that's not the long play, but I do think we should spend more time on this versus 30 minutes in an afternoon.
This is Chris Dable with Virginia Mason Franciscan Health. I agree with that. I think a lot of the information shared, at least at these cost driver meetings, have been referencing studies that are pointing to national evidence and information about, general national trends of what has happened in the past. They're not Washington state specific. And so I've just really been befuddled about, the thought that these hospital acquisitions and mergers are the cause of the cost driving problems within Washington state. And there has really been no proof of that other than pointing to general national study information. And being involved in the hospital, on the hospital side and working on the contracting side, I haven't actually seen, or I haven't personally experienced where these kind of mergers have resulted in huge increases on the hospital side. So I may be completely just, ignorant about where that's happening, where, mergers and acquisitions are causing increases in cost of members in Washington state. But now in this meeting, we're talking about, a lot of information being shared, and there's certainly a lot of information out there. I mean, CHARS, the Department of Health, the revenue streams, the revenue reports. There's enough information out there that you certainly should think that you should pull that together and glean something out of it. But again, it seems like step number one is that really what sorry, there's a noise going on here, but is that really what we should be focused on as a group that is trying to focus on cost drivers that are driving healthcare cost increases in Washington state? And everything we've seen so far, I mean, these acquisitions are probably on the commercial side is when those costs would be driven upward. And everything we've seen so far has indicated that hasn't been a huge, the cost drivers in our state have not been for commercial increases, and particularly specific to mergers and acquisitions. So to me, it was kind of a jump that, the board just decided this is the focus area when there's really no basic evidence in Washington state that points to that's where the focus should be. And I could be way off, but just my thoughts about that topic.
Bianca?
Maybe thank you, Krista. Those are, I think, very useful thoughts. Just to bring it back a little bit, I think to your point, there is, and I'm a researcher myself. I mean, that's my background. I certainly spent a lot of time conducting research, and certainly you can see the challenges of generalizing what's happening nationally to what's happening in the state. And I think to your point, there is a lot more information about what's happening around mergers and acquisitions nationally that I think has come to the board as an area of concern, and wondering exactly the question that you're posing is, what does that mean in the state of Washington? So I don't think, from my perspective, at least being on the board that for the cost transparency board, that it's not necessarily with an eye of saying, well, let's that what's happening nationally is exactly what's happening here in the state. I think the question is how do we leverage the data that we have existing to figure out how much activity is happening around M&As, and then what if any consequences there may be. And I think, as everyone's pointing out, we do already have a lot of data. So certainly it sounds like maybe the priority of this group is to say, maybe we don't need to collect more data. We do have a lot of data, but maybe we need to help advise the Cost Transparency Board to figure out how can we best connect all these data sets together? What is the useful way to move forward? So I think this is a good conversation to have. And I think that's exactly the hope that we get out of this data issues group, is to figure out what would you recommend as a priority questions and approaches to connect data among the data that we do have that you think is important for the board to consider.
Yeah, and I'd say it goes back to the cost driver study, and there was a consulting group that did evaluate that, but that work did not continue. So I'm not sure if we really know what's driving cost of healthcare or focusing on those areas, because that hasn't been the focus. It's changed, it's shifted.
I think this is the opportunity to certainly send that kind of message that there's some things that we think should be prioritized.
And Travis, you want to jump in here? You had some.
Well, yes, because we see data and interact with lots of health systems. I actually think when it comes to these issues of market concentration, cost, what services are provided within a geographic area, especially when you're looking at provider groups and ASCs and other entities, there isn't really very good data out there to do a lot of the analysis. We end up going to the parties to a transaction and we ask them for data, and they go and they provide data, but they don't tell us, hey, you can just actually go to this website and get all the data, right? That's not how it works, and no one says that to us. They say, I mean, they're certainly charged data, but they go and they do data pulls and generally are cooperative about it. But I would say that I actually don't think that this available state and federal data is as good as some folks described here, in terms of when you're actually doing this kind of economic analysis and looking at cost data, that it's just out there, that it's very easy. It actually tends to require quite a bit of work.
I'll second that.
Garrett?
Yeah, I mean, that's kind of the question, Jonathan, that I was going to ask you, which is I take your point and I take Krista's point that, we are relying on national studies, and I know you're familiar with them, that look at the impacts of consolidation on cost but my question would be, how would you measure, for example, if what you wanted to do was measure access as a result of a merger, how would you go about doing that with data that's available currently?
Yeah, I think that's the focus that I was hoping we would be utilized as an advisory group for, right? Not just sharing information and gathering high-level input. It's really posing those type of questions and seeing what we could do to answer those with the existing data sources that we have. That's what at least I see the intent of this group is really getting at the tax of really what are we trying to answer? We know the high level stuff, but what questions that we can do? What data sources are available? What are the strengths and limitations as far as addressing those questions? And I think that's where the strengths of this group would be. And I don't think we've been utilized to the point up to date. So
if I'm understanding you, what you would recommend is to make use of the expertise and experience of the people, on this committee to one, evaluate the efficacy of the data sources that currently exist to answer the questions that the Transparency Board is interested in. And then secondly, to come up with ways to measure, the important questions that you'd want to know the answers to with respect to issues like the ones we're talking about today.
Yeah, that's correct from my perspective. I think we oftentimes find ourselves referencing national and different things, but is it really happening here in the state? Can we dig into that? Can we provide some input on that? Because otherwise it's perceived, like if it's happening in Massachusetts, it's definitely happening in Washington State. Do we know that for a fact? And I think that's where this group can actually provide a lot of value and input as we dig further into this. As I mentioned, I think this whole group has had great experience with most, if not all, the data sources that have been shared. And I'm not going to say that there's not limitations across the board, but I think there's perceived limitations, and then it's just taken as like, well, this must be the fact. I would love for this group to get into the weeds and provide some greater insights and help validate some of the questions that are being proposed.
Maybe, John, I'm curious, I'm struggling a little bit with just trying to understand. I think this is that opportunity to do what you're asking us to do. So maybe I'm missing a little bit. Maybe the discussion questions may be too broad, and it's really, I think, meant to help us just facilitate this discussion. So I guess, could I ask you just as an example, next step from here? I mean, I think I certainly hear the message that this group has expertise. We're aware of what the data are. We are all aware that there are challenges with the data. I'm not clear whether there's agreement that we want some of the analyses to be done in the state of Washington. I think I'm getting the sense that that is an interest because we can't generalize what's happening nationally. We need to know what's happening in Washington state. And we seem to have the resources to do that and the expertise to do that. So what do you see as kind of like the missing next step?
Yeah, for me, it would be doing the actual analysis. I mean, we can look at the national perspective and get insights and what's happening across the nation, but is it really relevant here in Washington state? And can we provide evidence around that? I think that's what's ultimately missing, and that's what we want to push for.
Okay. So we want to find somebody to help move forward the actual analyzing of the data. And I think this meeting, and Janine certainly cut me off because I know you're certainly helping to lead this discussion, but I'm just trying to understand. I think the first step basically from the last meeting, if I remember right, is a sense of like, we didn't really know what was maybe available. So this was to make sure everybody on the committee at least has a sense of what is available and how people have been looking at it, because certainly we don't want to take for granted, it's a pretty good sized committee here. So we don't want to assume that everybody on the committee knows about all the data that's available. So I think that is the intent of this meeting, was to make sure that we're at least level setting, that everyone is aware of what is available so we can be creative about how to move forward.
And we also had Department of Health coming next meeting to just clarify their role, because there had been questions earlier, at least at the cost board level, as to, who does what.
And I think we also want to make sure we're not duplicating maybe something that is already happening, right? I think that probably is the other thing we want to make sure.
Right. And it is really to try to, we don't, how do you want to maintain or reduce administrative burden on providers providing more information if we already have access to it? But so to date seems there has been some disjointed data collection. Hence the question of, is there thoughts about more centralized? Is that it's not as actionable to be able to do that kind of analysis of access impacts, et cetera, if it's not all, it's not all one entity, if it's in 3, 4, 5 different agencies, and some can be shared and some can't, is there enough ability to pull it all together? Plus or minus whatever national websites are available to augment them, and then the dollars to do that analysis. If there isn't, the cost board doesn't have staff to do that at this point.
I think, as Ian pointed out, I mean, the work it does take to analyze data it's not a zero cost. And so I think to Krista's question of why isn't this already being done to some degree, my guess is somewhat related to who's paying to do the work, which does take the time. And so maybe that's a message too, to figure out like how to prioritize and find the right investments for that work to move forward.
This is Leah. Can you hear me?
Yeah.
Sorry,
Yeah.
I don't have a hand.
You're breaking up a little bit. Leah, you're breaking up a bit. We can't quite hear you.
Oh, can you hear me now?
Yes.
Okay. I just wanted to share, I mean, I don't think it's our job as an advisory group to do the actual analysis, but I think I differ a little bit with Jonathan in terms of how far to go into the data. I do think we could help guide it. And I think one question that would be helpful from the Cost Transparency Board around prioritization is, what question do you want to answer so that we could maybe be more clear about we do or don't think these current data sources are sufficient. Because I think every data source has limitations, but there's also I believe there has been quite a bit of work so far, including some of the reports we just heard about that are in Washington State, that are a strong indicator that we do not have sufficient data yet. But I also think instead of trying to boil the ocean with, sure, let's do a lot of reporting, let's try to figure out a few key questions to ask first. And then we could do some of that work that is around, well, we think some data could be enhanced to get you that answer, or know that the middle or need.
See, we may have lost her there. Yeah.
Basically suggesting that without the key questions, it's hard to assess if you have the right data.
Makes a lot of sense.
Yeah.
Yeah, this is Jonathan again. I agree. I mean, the questions are going to be key for sure. And just to kind of point out, like one of the presenters today said that the nursing FTEs were tied into the facility fees. I mean, nursing FTEs are reported at the federal level, at the state level. We could show you by cost center where they're reported. So just that fact alone causes questions, right? We all look at things differently. We have different inputs. And so when that was shared today, I was like, no, that's available in many different data sources, and I could show that person or the team where. And so dialogue, I think, is going to be important. It kind of goes back to what I had mentioned before. If we had an index or a library of this information, what's happening at the state level, so we can get our own information. Federal information is great because we get perspective and it allows us to compare to other states. So, I mean, there's pros and cons of the various pieces. And I think for this group, if we had a library of what was out there and taken the experts today that shared, they could start by putting in some of the pros and cons of each data source. And I agree, we're not the ones to do the data, but we are there to guide and influence it. And a big part of that is going to be based on certain questions and intent of how we're going about it.
Maybe if I can add to that, Jonathan, I mean, I'm someone who certainly have used the cost reports at Medicare, for example, and I can tell you that as a researcher, you don't actually have access to FTE data. So that's an example of perhaps what data you might be sending in. And then there's a question of who can actually see it and use it. And maybe as a researcher, I don't have access, but perhaps others do. And I think that's an important thing to discuss as part of it, is not even just what data are available, but who can actually use it and access it.
Yeah, I mean, that's fair. I mean, FTEs are done on the year-end financials at the Department of Health. You can look at the cost center reports. You can see how many FTEs are tied to each of the departments. You can look at the FTEs based on the cost report, maybe not to the granularity that you're hoping for, but you're able to look at it in some detail. So I think this, conversations around that and sharing insights and input around what's available, what's not available. There's the perceptions of so many of these things. And that's why I want to make sure before we're doing an ask of like, oh, we need X, Y, or Z, have we kicked the tires enough on what we have existing?
Great.
Well, looking at the clock, it's probably time to go to our next step slide, which at this point, again, this was created before this discussion, was the next meeting will in November, we'll be presenting briefly the Department of Health data or what they collect. And then more time to think about what we want to recommend and or suggest in terms of recommendations for the cost board for this task that they have asked us to do and how to craft our response back. So so stay tuned. We appreciate all the input today, and certainly thanks to our presenters and for those who are still on. We appreciate their time and effort to come today. And with that, I'll turn it back over to HCA, Rochelle.
I think you're turning it back to me, I believe, but thank you so much, Janine, for helping with the discussion today. Thank you to our panelists for providing all this information and to our committee members for being engaged in this conversation. Before I bring the meeting to a close, I realize I think I skipped over a slide at the very beginning after tab 1, introducing our newest member who is not here today, but we will have him introduce himself at our next meeting. But David Giuseppe is joining us as he's the VP of the Healthcare Economics at Community Health Plan of Washington, with expertise in healthcare data and spanning behavioral health, risk adjustment strategies, and value-based purchasing. And he serves on the Finance Technical Advisory Committee of the Universal Healthcare Commission. So just didn't mean to bypass that, but wanted to mention it as for the group to know who is joining us hopefully next time. So with that, that brings us to the end of our meeting. And in November, we'll be hearing from the Department of Health in Washington. And after hearing from them on various data streams across the agency that touch upon health industry, including licensure, charity care, and certificate of need, we will also discuss possible policy options around the business oversight, which can help address affordability in healthcare. So again, the recording and meeting materials of this meeting will be posted shortly on our website. Thank you again to everyone for participating today, including our presenters. And our next meeting is scheduled for Wednesday, November 20th. And the discussion will follow from the September 19th cost board meeting and a review of the 2024 cost board report to the legislature. So thank you, everybody, and I look forward to seeing you again at the next meeting. Have a great day.
Thank you.
Or great evening.
Thank you.
Bye.
Thank you.